morning, everybody. Yeah, so this is last minute, so this talk is not as updated as I might like. There's been a lot of interest in this space more recently over the last few years. In part, I think, because of some of the work we actually did a few years ago in this area. So let's see here. Let me see. You guys can see my slides right now. I'm not in presenter mode.
Oh, it looks good.
Okay.
Looks good.
Okay. So, for everybody here should have a good familiarity with sleep apnea, but sometimes I've given this talk to others that may not be as familiar, particularly as an infectious disease audience. But this is just a recording of a patient that has a sleep apnea. You can see here in the flow signal that there is an absence of breathing, during which there's persistent obstructed efforts, as noted by an esophageal balloon in this particular example. During this period, there's a drop in the oxygen level with a significant desaturation, and the apnea itself is punctuated by an arousal. And obviously, in patients with sleep apnea, this is something that's occurring over and over throughout the night. For those of you who listened to a talk I gave several weeks ago, I talked a little bit about the concept of the critical closing pressure. And at least the way we think about that is that, the critical closing pressure really describes a clinical spectrum of patients from health to disease, where over a relatively narrow range of pressures, we can determine the relative degree of obstruction of the upper airway. And one of the things we know, obviously, is that there's a close link between obesity and sleep apnea. And it's speculated that, as one increases their weight, that this may be one reason why collapsing pressures can increase. Under non-REM sleep conditions, this is conditions where you have both anatomic and neuromuscular aspects that are contributing to the state of airway patency. But under conditions of airway blockade, neuromuscular tone is eliminated. And we can see that there's differences in airway collapsibility between those that are normal and those that have sleep apnea, indicating the importance of anatomic contributions. So in previous work, our group had done, we've shown that there's differences in both the degree of anatomic contributions to airway collapsibility, and that patients with sleep apnea may in fact have impaired neuromuscular responses as well. And so this has really led to sort of a two-hit hypothesis model that individuals develop sleep apnea because of both impairments in anatomical loads to the upper airway, as well as impairments to compensatory neuromuscular responses. And it's really this balance, if you will, that's going to determine whether you do or do not have sleep apnea. Obesity itself is one factor that can clearly impact anatomic loads on the upper airway. But the question is, could it potentially have impact on compensatory neuromuscular responses? And what might be the mechanisms and pathways related to that? And so when we think about obesity itself is complex. And so when we think about it really in more simplistic terms, we tend to look at issues of upper body obesity or the apple distribution of weight versus a lower body obesity or a paired distribution of weight. And it's really the upper body obesity or visceral adiposity, if you will, that seems to be most associated with development of sleep apnea, as well as other comorbidities that are part of a metabolic syndrome. And so if we think about, obesity itself, one possible model or hypothesis, again, if we're thinking about this teeter-totter model where, you have this balance of mechanical loads that are going to put you at risk for having sleep apnea and protective neural responses that might protect you from those anatomic predispositions. The question from an obesity standpoint is really, this sort of balance, if you will, of possible adipokines at a molecular level and what that might do. In particular, visceral fats are going to tend to result in the secretion of certain adipokines that may have more of an inflammatory component compared to subcutaneous fat, which may actually produce adipokines that may be more protective in some sense. And so, at least from the perspective of thinking about sleep apnea in the upper airway, there's some evidence to suggest that leptin itself may be beneficial in terms of it being a ventilatory stimulant, whereas the other inflammatory cytokines like TNF alpha and IL-6, in terms of the inflammation that's caused, may actually may be adversely impactful in terms of sleep apnea, not only in terms of sleep apnea increasing these levels, but it might feed back in terms of worsening the function of the upper airway. So why HIV and sleep apnea? Why think about these two in the same sentence? So we know that HIV patients clearly have a lot of issues when it comes to fatigue and sleep disruption. And so fatigue is reported in about 65% of patients with HIV infection, regardless of whether they're on HAART or not on HAART therapy. There's clinical reports of sleep fragmentation and altered sleep architecture early in HIV infection, and alterations in sleep architecture itself, independent of HIV, have been associated with increased circulating TNF alpha and IL-1 beta. The HIV GP120 protein induces IL-1 beta expression in rat models, in looking specifically in the hypothalamus, and low doses have led to increased wake, decreased slow wave sleep, and REM sleep when it's looked in these animal models. So this is a recent publication just looking at how common sleep disturbances are in people living with HIV. And you can see that the darker bars are for women and the lighter bars are for men. So you can see if you just look at, sleep quality, a component of sleep health, just looking at the PSQI, the Pittsburgh Sleep Quality Index, that the prevalence of people having a score of 5 or more, which is indicative of a sleep disturbance, is elevated. Depression scores are elevated as well. The diagnosis of sleep apnea is fairly common, insomnia and sleepiness as well. So these are all complaints that are seen in those with HIV. When it comes to HIV and sleep apnea, really the first case series, at least that I'm aware of, with respect to this, was published in the 90s. And this would have been just when I was coming out of medical school at the time. So this was a case series reported by Larry Epstein up in Boston, just looking at 12 HIV infected patients who happen to have sleep apnea. And what they found in terms of just their case review was just how profound the degree of adenotonsillar hypertrophy was in those patients. And we have to remember that this is in the pre-HAART era. And so, this was something that was noted with respect to that. So, with the advent of HAART therapy, HAART was incredible in terms of the transformation that it had in terms of managing HIV infection. But HAART therapy itself has some potential sequela. And one of the big things that have been associated with certain HAART therapy is this issue of lipodystrophy. And so, body composition changes are fairly common. And one component of this is what we would call lipoatrophy. And so typically this is seen in therapy regimens where they may have included AZT at one point, as well as D4T. And these drugs, these thymidine analogs, will cause mitochondrial dysfunction and adipocyte apoptosis, which then leads to inflammation. You can see here sort of there's this loss of fat, in the legs. Here you can see sort of the sallowed cheeks in this particular individual. So, in addition to lipoatrophy, what's interesting with these antiretrovirals is that they can cause lipohypertrophy. This is a little bit harder to quantify and express compared to lipoatrophy, where there's some clear guidelines in terms of how to note it. So the etiology is unclear, but it's thought to be related to certain protease inhibitors, versus whether it may be lifestyle factors. But typically what we sort of associate with classic lipohypertrophy in this setting is the appearance of a buffalo hump, as well as a increased visceral adiposity with a protuberant abdomen. So this is a work that I worked with Flip Smith and Joe Margolick while I was at Hopkins. And you may be aware of a large study called the multi-center AIDS cohort study. That's a longitudinal study looking at the natural history of HIV infection and its treatments. It's a classic cohort, if you will, where a lot has been learned. And what we did was look at the particular cohort that was based in Baltimore, which is called the SHARE cohort. And the notion here essentially was looking at the HIV infection and HAART, with the notion that HIV infection itself may increase the production of cytokines, just based on some of the slides I showed you before. And that this increase in these cytokines, if you will, may then disrupt sleep and therefore lead to daytime dysfunction. From the standpoint of HAART therapy itself, the initial kind of hypothesis was really, that HAART therapy itself may result in the development of a lipodystrophy. Lipodystrophy itself may then feed forward in terms of increasing inflammatory cytokines and disrupting sleep. But then, of course, the presence of lipohypertrophy would then increase the risk of developing sleep apnea and therefore contribute to daytime dysfunction in that setting. So this is the conceptual framework that led to the grant that was funded, and then we did this work. And so again, it's just this notion, instead of obesity, could HIV and HAART therapy in some way, affect anatomic loads and contribute to sleep apnea, or could it affect compensatory neuromuscular responses in some fashion? So this study was called Siesta, Study of Immune Effects on Sleep Treatment and Apnea. This was based at the Bloomberg School of Public Health, and the study had multiple goals in terms of looking at whether sleep apnea, fatigue, and sleepiness were more common in HIV positive men compared to HIV negative men. It was also to determine if sleep apnea is associated with fatigue and sleepiness. The third point was to see whether HAART itself was associated with an increased prevalence of sleep apnea and severity of sleep apnea, and to look at predictive abilities of common anthropometric factors in predicting sleep apnea in this population. So again, from MAX, we recruited from primarily the Baltimore site, but we ended up supplementing with participants from the Pittsburgh site. It was a small study, but we recruited individuals using flyers that were participating in the study. And we were able to recruit 60 HIV negative individuals, about 60 HIV positive individuals on HAART, and about 40 individuals that were HIV positive but not on HAART. And HAART, not on HAART, was defined as not using HAART in the past year. All participants that were HAART negative were invited to participate just because it was a smaller group, and then random samples of the other two groups matched on age and race were invited to participate in the study. In terms of the overall study design, we took a fasting PM blood sample. We did anthropometric measurements and did a neurocognitive assessment at the time. We then, on the night of the sleep study, had them fill out a number of quality of life questionnaires. They performed a sleep study in our CRU. And then the next morning, we got a fasting blood sample and then obtained pulmonary function test as well as a DEXA scan. This is the demographics of the participants in this study. You'll see from an age standpoint that this was a middle-aged group. The HIV negative population was a little bit older. In terms of education, it was similar. In terms of the race distribution, reflects, Baltimore City, where is a greater proportion of African Americans. You'll see just the statistics here in terms of their HIV and AIDS status here. And you'll also see that there's a high prevalence of hypertension, as well as diabetes. You will see, I think on the next slide, the BMI will be noted. Yeah, so you'll see here in terms of the BMI, which was, one of the issues with this particular study, which is that, our HIV positive participants were of a lower body mass index at around 25 compared to our HIV negative population at 29. If I had to redo the study again, I probably would have tried to recruit for matching, but it would have made recruitment a lot more difficult. And I'll show you some of the analyses we tried to do to compensate for that. But whereas about a third of the HIV negative population was obese, only 12% of the HIV population was obese. But I think it makes for some interesting, I want you to remember that because it's interesting as we go through the particular results here. As well, you can see in terms of, just the waist to hip ratio, which is another indicator of, central obesity. The HIV negative population was at around 0.96. The HAART population, interestingly, had a little higher waist to hip ratio, which suggests a component of lipohypertrophy. When you use observer-based measures of lipodystrophy, you can see that in those that were on HAART therapy, there was a higher prevalence of a lipoatrophy as would be expected. However, lipohypertrophy itself was similar across the three groups. So in terms of looking at this question of whether, how frequent is sleep apnea, fatigue, and sleepiness are, and whether it's more common in those with HIV compared to those without HIV. So these are the data here. And so what you see in terms of fatigue, those on HAART therapy had much higher levels of fatigue, which they expressed as being more than 3 days or more than 2 weeks at the last assessment that was done. This is in line with what's been reported in the literature. When it came to the issue of sleepiness, what you'll see here is that the mean scores or the median scores were 8. So this was not generally a sleepy population. That said, if you ask the question of, well, what percent were sleepy based on an Epworth of 11 or more, about 25 to 30% of the population of the sample was sleepy. There really were no difference in terms of macro sleep architecture between the three different groups of patients. So in terms of the prevalence of sleep apnea, in this particular study, we did look at the prevalence of sleep apnea and report primarily in the main paper in terms of using the 3% or arousal definition. But we also report in the supplement on the Medicare or 4% definition. And I think what we found that was rather surprising was just the large prevalence of sleep apnea in these three groups. We're talking about a range, if you just define sleep apnea by polysomnography with an RDI greater than or equal to 5, we saw anywhere from 70 to 85% of patients having sleep apnea across these three groups. Clearly, as you sort of change the definition of sleep apnea, whether it's 10 events an hour or more, or 15 events an hour or more, those prevalences will go down correspondingly, but still are rather quite high. When you then segregate the population of those with a BMI less than 25 or those that are not obese, the prevalence of sleep apnea defined by 5 events or more, 5 events an hour or more, is still quite high. It's somewhere between 50 to 70%. And so it raises this question, if you will, why is the prevalence so high in those that are HA, across the populations, first of all, and is this higher than what we would see perhaps in like sleep heart health study? And then, why is it so high in these HIV positive patients when the BMIs are rather low to begin with? So this slide just shows you the distribution of sleep apnea in terms of box plots, so that you can see the median values here are usually in the range of what I would say mild sleep apnea. But there's a good portion of patients that have moderate to severe sleep apnea across these three groups. And again, oops, if you go and you just look at those individuals that have a BMI less than 25, you can see it's fairly comparable in terms of the range of values that you think. Somebody might have a open mic, might want to go ahead and mute. This is just another study that was done in the last few years after we had done that study, just looking at the prevalence of sleep apnea in a HIV positive sample. This was just a cross-sectional study as well. But interestingly, what they were looking to do is look at sleep disturbances, but then just happened to note as well a similar high prevalence of sleep apnea. In this particular study, they were looking to transition patients from a HAART regimen that was on efavirenz to a non-efavirenz regimen, just because efavirenz has been noted to be associated with issues of sleep disruption. And so they had excluded patients with known OSA or thought to be at risk of moderate to severe sleep apnea. And then they took this population and they put them through a in-lab sleep study. And what they found, even before they did the randomization, was that patients, there was a rather high prevalence of sleep apnea at around 60%. Again, mostly in the mild range in this particular case. Of note, 60% of this group had poor sleep quality based on an elevated PSKI score. Others have looked at this issue of sleep apnea in the HIV population in a veterans population. This was done by Ken Kunisaki. And so, they looked at the issue of OSA prevalence based on ICD coding, which has its limitations, obviously, because, ICD coding, if anything, is going to tend to underestimate or under-identify the degree of sleep apnea that's there. What they noted was that the prevalences were much lower than what you see when you do sleep studies, at least in the Siesta study as well as the other study I just showed you. But they saw rates of about 4% in those HIV positive versus 12.4% in those that were HIV negative. So if anything, having HIV seemed to be protective when you looked at it in this way. Of note is that there is a BMI difference, and those that are HIV negative have a much higher BMI compared to those that are HIV positive, and in part they explain some of that. So is sleep apnea associated with fatigue and sleepiness in these groups? So in the Siesta study sample that I'm talking about here, what we found is that fatigue was less prevalent in men with sleep apnea than men without sleep apnea, although this didn't rise to a level of statistical significance. So more so than fatigue being associated with sleep apnea, what we found really was that sleepiness itself was more likely to be associated with sleep apnea. And those that had moderate to severe sleep apnea were sleepier than those that had mild sleep apnea. And so scores of Epworth scores of 9 versus an Epworth score of 6.7. So that's a fairly large difference between those two groups. And an Epworth score greater than 10, which we identify as being sleepy, was found to be associated with having a diagnosis of moderate sleep apnea with an odds ratio of about 2.7. independent of HIV or heart status. And another study that's been done, just looking at sleep apnea symptoms and associated with fatigue. This is a little bit different, where they did see associations of apnea symptoms with fatigue using the FACIT fatigue score index. So in this case, as scores go down, you actually have more fatigue. And so what you'll see is if there was reported symptoms of witnessed apneas, those individuals reported more fatigue than those that did not report witnessed apneas. If you reported low sleep duration, you had more fatigue compared to those that had higher sleep durations, if you will. And so opioid use, antidepressant, depression status were all associated with more fatigue, but witnessed apneas at least appeared to be associated in this particular study. The next question was really, to determine if heart therapy was associated with an increased prevalence and severity of sleep apnea. And in this case, what we did was to perform some multivariable models in terms of looking at this. And in unadjusted models, just like in the Kunisaki study, looking at in the VA population, if you had HIV infection, it appeared to be protective, if you will. BMI was a predictor of sleep apnea status as well as age. Race was not. When you then moved into doing the adjusted models, BMI and age continued to be independent risk factors for determining whether or not you would have sleep apnea. However, the HIV status itself was no longer statistically significant from that standpoint. When you then go ahead and stratify patients by their HIV status and their heart status, and you look at whether BMI and age predict, within the HIV negative population, we found that BMI would predict whether or not you have sleep apnea, and we looked at different definitions of sleep apnea. And in the case of if you were HIV positive and on heart status, BMI would predict. What was rather fascinating is that if you have HIV but are not on heart, BMI does not seem to predict the presence of sleep apnea. In the case of age, across the three groups, this was not found to be statistically significant. It was only found under one definition, but this is probably more due to chance than a true finding. So one of the things we did to sort of look at this data set a little bit further then was really to look at this issue of heart status a little bit further. You'll remember, when we identified the heart status group, what we said is that we looked at, you were considered to be heart negative if you hadn't had any exposure in the prior year. And so what we did do was to do a further sub-analysis where we looked at our two populations, and we basically said, well, what if we said you had never been exposed to heart, but were HIV positive, versus those that had had any prior exposure to heart, even if it was more than a year ago. And interestingly, when you look at it in that way, what we seem to find is that any heart exposure seems to be associated with a higher prevalence of sleep apnea than never ever having any exposure to heart therapy. So suggesting, again, that there may be something about the type of medication regimen that may predispose your risk developing sleep apnea over time. So, I noted a little bit earlier in this talk that there was a rather high prevalence of sleep apnea in this population, even in the HIV negative men. Some of it may be the definition in terms of using a 3% arousal, which is very liberal, versus a 4% only definition. But it does raise a question of whether the men in the MAX cohort that were HIV negative are really representative of the general population of men, or whether they have other exposures or behaviors that might actually predispose them to having sleep apnea in the first place. And so one of the analyses we did was to go ahead and take the Sleep-Heart Health study and to go ahead and match our HIV negative men to community participants. And we went ahead and we matched them on BMI and age. And you can see that they were fairly comparable after we performed the matching exercise. And so when you look at the data, and this is now data showing the prevalence of sleep apnea using the 4% definition, because that's how Sleep-Heart Health data is presented. And so you can see that the prevalence in this population in the matched population was about 43%, compared to in our HIV negative men was about 69%. And in the HIV positive patients that we had, it's around 50 to 55%. So it did suggest that there is something different about these HIV negative men participants in the sample that we studied compared to the a normative population, trying to use these similar definitions of sleep apnea. So it's kind of interesting. Don't have a clear answer in terms of why that might be. In terms of looking at this issue of lipohypertrophy and the association with sleep apnea, again, this is an observer-based definition and assessment. So when we look at that in HIV positive patients, lipohypertrophy was a marker for having moderate to severe disordered breathing. In HIV negative men, however, interestingly, the presence of lipohypertrophy, again, how you define that, was not associated with sleep apnea. So kind of looking at this and just kind of summarizing, what we seem to find in this, fatigue was certainly more common in HIV positive men than HIV negative men, more so if you were on HAART therapy. Excessive sleepiness was similar across the three groups, as I indicated, with about a third of patients being sleepy. Sleep apnea itself was associated with sleepiness, but not with fatigue based on the measures that were collected within the max cohort. And the prevalence of sleep apnea was high across the three groups. And it was high across the three groups, even when you limit the analysis to participants that have a BMI less than 25, which is rather fascinating, when we think about the fact that we mostly think about obesity as being the major risk factor for developing sleep apnea. Sleep apnea prevalence really did not differ by HIV infection status or HAART status after adjustments for age, BMI, and race. Again, however, there's this unusually high prevalence across the three groups compared to when we look at community dwelling men, like as in Sleep-Heart Health study. And this suggests that the men within the max cohort in general are at higher risk of sleep disordered breathing. And that raises some interesting questions in terms of thinking why that might be. Could it be due to other factors related to lifestyle or cohort membership independent of HIV status, whether it might be illicit drug use, presence of other infections such as hepatitis C or other behaviors, such as smoking, which are a little bit more prevalent in this particular cohort than it is in maybe the general population. Associated with moderate to severe sleep apnea, and that HIV positive patients with any prior HAART exposure had a higher sleep apnea prevalence than those that had never been exposed to HAART in the past. And finally, non-obese HIV positive not on HAART men had a higher sleep apnea severity than the other two groups, suggesting a possible role of HIV infection in the development of sleep apnea. One other thing we sort of looked at, again, we were fascinated by this issue of just the at least the BMI not being a predictive a factor in those that were HIV infected, but not on HAART therapy. And so we just looked at the predictive ability of common anthropometric factors to predict sleep apnea. And so to do that, we looked at the basic simple correlations, looking at BMI, waist, neck, and waist to hip ratios. You'll see in the HIV negative population, there are fairly decent correlations between these metrics as we would expect compared to the presence of sleep apnea. Similarly, we saw that in the HIV positive and those on HAART, but rather surprisingly, again, in those that were not on HAART, no matter the measure we used to try to look at the association between an obesity measurement, we didn't see any relationship. When we looked at the DEXA data that we collected in terms of looking at total fat, just the trunk fat component or the trunk fat relative to the entire body fat, again, in those that had HIV infection but were not on HAART, there was no clear association with sleep apnea. And so when you look at receiver operating characteristic curves, in terms of these different metrics and whether they're associated with the presence of sleep apnea or not. The dark circles are for BMI, the squares are for neck circumference, and the diamonds are for using a waist circumference. You can see again in the HIV negative and HIV positive populations that these metrics are predictive in determining whether you have sleep apnea or not. But again, when you look at those that have no HAART exposure, that these factors really do not predict whether you're going to have moderate to severe sleep apnea versus not. So, in terms of looking at some of the characteristics, of this HIV positive no HAART group, what we did was we just divided them into those that had moderate to severe sleep apnea versus the rest of the group, and we were trying to see if we could identify differences that might explain what it was. And really, the only thing that was found to be associated, if you will, was the viral load here in this case. We didn't see it, when you look at it with the HIV viral load greater than 100,000 copies, but those that had greater than 10,000 copies, this was more prevalent in those that had moderate to severe sleep apnea versus those with mild sleep apnea. When we look at median CRP values, it was elevated in the moderate sleep apnea group at 3 versus, a little bit less than 1 in the mild sleep apnea group. However, it was a borderline statistical significance. When you look at the distribution of just the viral load in patients as a function of just the spread of the AHI, you can see that in those that have a higher viral load, there seems to be, on average, a little bit higher sleep apnea severity compared to those that have a lower viral load. So multivariable analyses was performed. We looked at both CRP and HIV RNA levels with respect to this. A CRP level greater than 3 was associated with moderate to severe sleep apnea with a high odds ratio, as well as the viral load had a higher odds ratio of being associated. However, these associations were not seen when you looked at the HIV positive group that were on HAART therapy, just as a comparison. So, in summary, for this particular section, waist circumference, neck circumference, and BMI were discriminative in terms of you assessing your risk for moderate to severe sleep apnea in HIV negative men. These anthropometrics tend to be a little bit worse in the HIV positive men on HAART, but still predictive. But it was no different than chance in those that had HIV but were not on HAART. And so this finding, is potentially suggestive of the fact that, uncontrolled HIV may result in a systemic inflammation that may somehow contribute to your risk of developing sleep apnea. And so it just raises this question in terms of a causal pathway, whether inflammation in some fashion might be depressing neural control of the upper airway in some fashion and leading to sleep apnea. Another hypothesis would be, and I'm not showing it on here, is there something about the inflammation that's doing something to change the deposition of fat, perhaps, and then that also increases your risk of sleep apnea. And so this is a hypothesis, I think, that still sort of is still being looked at and thought of. I know there are some groups that are looking at particular just upper airway function and HIV status and looking to see whether or not there might be differences based on HIV infection status as well as treatment status, and whether it might alter some of the components we think about as intermediate phenotypes in sleep apnea. So, I'm going to go ahead and end there, but of course, I just want to recognize just all the people that were involved in this. Again, this was a grant that Joe Margolick and Flip Smith had obtained, and I just had the luck in terms of running this particular aspect of the study. It's true, it takes a village in terms of this, but this is one of the more fun studies I was involved with, working with both the SHARE group at Baltimore. We also worked with the women's group, where we looked at a small sample of patients, but ultimately that aspect didn't continue because of funding related issues. And I want to thank the sleep group at Hopkins that I worked with respect to this. Of note, this is the NIH has subsequently funded a larger study where the study is to actually perform sleep studies across all of these sites that contribute to the multi-AIDS cohort study to see if we can validate the findings that we found in this study. My understanding is that those data have been collected at this point, but there are reports still to be published at this point with respect to the findings from that study. So it's going to be very interesting to look at that. So I'm going to stop there, and I'm not sure if there's any questions to answer, Kingman.